Class is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining the November Virtual Pulse webinar series. In this session, we are going to be going over a day in the life of a radiology director. Before we get started, I did want to go over a couple housekeeping items. If you are having any issues with your sound, you are able to check in the audio section of your dashboard to either join via your speakers, or you could join via your phone with the dial-in number and passcodes. We are going to be sending an archive of this recording after, so you will be getting that in the next week or so. And lastly, we do really appreciate your feedback. So after the webinar, a survey will launch automatically, and we'd like to hear from you. Let us know how we did today. So let's go ahead. I'm going to kick things over to Russ Cardwell, who will be introducing our speaker today and going over our agenda. So Russ, why don't you take it away?
Very good. Thank you so much, Lisa. And again, thanks for I think our fourth in our series of virtual pulses this year, where we talked about some reimbursement changes and different legislation that's affecting our industry and different business models. And again, we thought we would change it up today and have a talk with Bill Algee, whom I've known for many years. We were talking probably at least 8, but probably longer than that, years together. But Bill is I would say, an icon in our industry. He's been a president of AHRA and served on the board of directors, as you can read on the screen, and very active in other areas of our industry. So we're delighted to have Bill Algee, the Director of Imaging Services from Columbus Regional in Columbus, Indiana. So thanks for being with us today, Bill.
Hey, thank you very much. Appreciate it.
Yeah, so what we thought we would do is, again, this is just a kind of open dialogue where we continue to talk about issues that face our industry, and we wanted to kind of talk about what is a day in the life of a radiology director like. So first of all, before we jump into some of the questions, maybe you can tell us about yourself, your experience, and a little bit about the market that your organization serves.
Great. Well, first of all, happy Radiologic Technologist Week to everybody that are techs or have techs work for them. It's a great week to be doing this. I didn't realize when we scheduled this that it was going to be this week, but it's pretty cool. As a technologist myself, I'm very proud to be one. Like you said, my name is Bill Algee. I work at Columbus Regional Hospital, which is located about 40 miles south of Indianapolis in Columbus, Indiana. On November 2nd, I was here 35 years. So I, fresh off the farm, right out of X-ray school, I came here about 6 months after school, and have not left. So I've had a couple of opportunities to leave, actually more than a couple, but always found this to be a good place to land. And found that the organization's been a great place to work, and they've always let me grow and do the things that I want to do and grow as a professional. So that's been great. We are a community-based hospital. 250 beds is what we're licensed for. Like most of anybody else that might be listening, it's a hospital-based system. We are trying to work toward single beds, so we try to keep single beds. So when we get to about 150, people start freaking out a little bit. So it's like, oh, we're busting at the seams. So we start making up, adjustments for that. But overall, it's a great community hospital, and it's like very vibrant. We've done a great job of staving off the big groups from the north and the south. Louisville, we're like kind of nestled between Louisville and Indianapolis, but done a great job of holding our own. So that's been very important for us. So.
Very good. Yeah, thanks for that. Thanks for that update. I think it's good that people understand what market you're serving and the challenges.
Russ, let me add one more thing. I did forget to mention. So we have a main campus, and then I also have an outpatient imaging center called CDI, which is Columbus Diagnostic Imaging, not the old CDI, Centers for Diagnostic Imaging. So I just want to thank them for changing their name. That was very helpful for us. We really appreciate that. And then we also have a breast health center too that is literally across the creek from us. So there you go.
Nice. Yeah, that's great. No, that's great. Thanks for adding those other locations. So let's jump right into it. And again, this will be like a fastball right over the plate. But I think in our industry, I know in our industry there has been reimbursement impacts that have affected radiology for years. I mean, really, I think going back to the Deficit Reduction Act of 2006, that really, in my mind, is what kind of started it all. But there's been a number of pieces of legislation that have affected our industry. But last year, the budget neutrality rule basically it was supposed to be a dire like 10 or 11% cut, and there was a late minute adjustment to make it only a 4% cut. But what does that mean? We're hearing that there could be another round of those cuts. I've heard somewhere in the 6% range for next year, and maybe it'll go right up to Christmas again before there's some saving legislation that makes it less. But can you talk about what impact that might have on you? I know as a community hospital, you hire a third-party reading group, but it probably still has an impact on what happens, for the patients you serve. So could you talk about that for a little bit?
Yeah, I think that, whether you have your own group, a third-party group, a big conglomerate group, of radiologists, we have to be partners. So we have to work together. We have to, help support each other in a variety of different ways. So, yeah, definitely something that we're looking at even more now. I think the latest thing I've seen, to your point, is then, next year maybe another 3% cut. And I don't, that can't keep going. There's a lot of things going on, I think, in our industry right now in healthcare and in imaging that, and we're going to talk a little bit more about those things with human capital and those kind of things, that just have to, at some point, correct themselves. Otherwise, there's going to be a huge mess. But we do have a group that is a local group to our facility. We have not had a national group. I know a lot of facilities have went to more of a national group, and we really nestled here in Indiana. We wanted to keep a hometown feel. Most of the guys live here. If not, they know the guys that they've hired because they've worked with them in the past. So they're a pretty tight-knit group, which is great. I think we all have a stake in the game of trying to make sure that we help our imaging partners, the radiologists, making sure that they can survive. And I think right now it's a struggle, just in imaging in general, from that perspective, especially with radiologists. I mean, I think that there's not radiologists falling out of the sky. They're not graduating from school 10 times more than what they did 10 years ago. The number's shrinking, and it's making it worse. And as doctors are going to medical school and they're looking at what specialty they want to go into, and they see these cuts keep continuing to happen, it does, do I really want to do that? Is it really going to be here in next years? Is it going to still be a local group or go to a national group? And all of that stuff plays into their decision making.
Yeah, so I've actually heard some of the same things. The enrollment of some of the residency programs is getting lower year to year. And again, they hear things like AI, artificial intelligence, which we're going to talk more about later. But I think the reimbursement, the AI, all that kind of contributes to this factor of fewer younger people want to get into the field. So yeah, we do want to talk about how that will impact our industry. Just focusing on the cost reduction for a moment. So what is your organization trying to do to reduce costs, or what are you hearing from other radiology leaders to try to reduce costs, we've got inflation on the one end and you've got lower reimbursement on the other end, and that's squeezing you in the middle. So is there any ideas you can share with our colleagues on the phone today, or maybe what other leaders you're hearing from talk about as strategies?
Well, I think it's not business as usual, that's for sure. Anything we were doing 2-3 years ago, we don't have that luxury anymore. I think most people use some kind of a benchmark data to look at productivity. They look at that for, just and where, what kind of, your volumes, that's one of the things that we all look at and track. At one point in time, I think people were benchmarked at the 50th percentile, maybe 60th percentile, 40th percent. Now people are benchmarked typically at the 40th percentile, some at the 30th percentile. And the challenge that comes with that, good, bad, whatever, is when you get to those points and you're running on a pretty low reserve, so to speak, with people, when you do have a situation that's going on right now, and it's going on everywhere, and is people leaving hospitals to join agencies, and that's just a challenge. So I think, to your question, what we've really tried to do is try to figure out where the balance is and what makes sense. Some of the stuff we've tried to do is when we look at capital and purchasing capital equipment, that is a huge expense. Radiology and surgery probably spend more money than anybody else on capital in an organization. Obviously that's a huge dollar figures. I've looked at in the last couple of years, I've spent more time looking at, used equipment, refurbed equipment, manufactured, recertified equipment. Because does that make more sense? Does that kind of get you through the realm? I think the idea, at one point in time, and every time we buy any equipment, I always ask, what's the lifetime of this equipment? And you always put 7 years. I think anybody that's listening to this will probably say they put 7 years on it forever, and then it's turned to 10, and now you just go, God knows. Until you can figure out how to get the money, until you can figure out how to, make a good case for it. But, and it doesn't mean we don't. I mean, it just means that, you really have to look at things differently, because those dollars all have to go somewhere. And it's, as you said, it's really challenging, and, controlling expense is really, 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 I think, more of a challenge today. And I've said this before. I've said this before a couple of years ago, on a discussion with with someone that, more today than any other time, we're being squeezed to do more with less. Today we're being squeezed to do more with less, right? But I don't, I don't have a magic wand. If I had a magic wand, I'd probably be sitting somewhere on a beach. But it is a challenge for sure, and I think you have to look at all different aspects. I think from managing that perspective too, you have to look at it. It's not business as usual. So controlling costs, it looks at, do we need the same number of staff here at the same time that we've always had them here? We've always, for a while, I think a lot of people have always worked 12-hour shifts, or they've always worked, at one point we had 16-hour shifts, and now they've come back and they've said, yeah, you don't get to do that anymore. But you have shifts that work Monday through Friday. So you have to be, now we're really challenged to be a lot more flexible, and trying to meet what our staff needs are, as well as trying to meet, productivity levels. So it's quite a challenge, and I wish I had the magic bean, because if I did, I would sell it.
Well, it sounds like you're definitely looking at the capital equipment expense as one way, with the refurbished equipment as one thing, and productivity measures, but then also trying to balance that with your employees. So that's, looking at all the main things: people, process, and technology. We talked about equipment there for a moment. Maybe we can just tag on to that with this next question, which is, we know with supply chain issues that's delaying the delivery of some equipment. Now, you talked about the refurbished market, so maybe that's already here in the U.S., but other equipment we know is manufactured, overseas and needs to get shipped here. So are you still looking at new equipment? And if so, do these supply chain issues, is that having an effect on the care you can provide your patients?
Yeah, definitely. I mean, I have, talking about the day in the life of a director. So I've got 3 projects going on right now: replacing some rad rooms, doing a PET, replacing our PET CT, and also a CT scanner. So, hey, why not do 3 great big projects all at once? Why spread them out throughout the year? That makes no sense. So to your point though, one of the vendors that we've been looking at and having some great conversations with is, the lead time on delivery is, 25, 26 weeks. I can remember a time when they would say, if you cut the PO on this day, I can have it to you in, 90 days. Because honest to God, I'd not heard 27 weeks or 25 weeks. And when he said 25 weeks, I was like, excuse me, did you say 25 weeks? And come to find out, it's not, it's not just one vendor. It's happening to a couple. And, whether the vendors are here, based in the United States and manufacturing in the United States or not, it's kind of irrelevant, because we all know things come, all those parts come from all over the world. They're coming from, somewhere in China or somewhere like that, they're manufactured in Germany. There's just stuff everywhere. And so, yeah, it's going to be, we have got a little bit of a time frame, and I had to tell some cardiologists that, you know, we're going to get what we want, what we need to continue our project that we're working on, but it's not going to be tomorrow. And it's not my fault, which I thought was the most important part. Because they're, you know, they're always looking for a fair, you know, finger to point at. So, but I think in general, you know, I think that's, you know, supply chain is an issue. It's going to be, there was a local business discussion here yesterday. I didn't get to attend it, but one of the things I was told out of it was they were talking about, you know, the only people right now that have it worse from a supply, meaning capital perspective, than hospitals and healthcare is trucking industry. And, you know, everything anybody gets in the world comes on a truck. So that's a huge, huge issue for sure.
Yeah. So are you extending, I mean, with, I guess for new equipment that you don't have, it would be a delay of getting those projects online. But for ones where it's a replacement, I guess you're just servicing with the older equipment that much longer until the new equipment comes.
Yeah, you're stretching. You know, and like I said before, I think a lot of us are in this shape where we didn't replace things in 5 years, 7 years, even 10 years. You know, it works. You know, it still provides great, you know, good images. It's not, you know, bad in any way, shape, or form. But, you know, you do have a little more time where you have some downtime, some unexpected downtime, you know, and, you know, technology has, you know, there's been a lot of advances, so you want to take advantage of those. So, yeah, you just have to, we got to keep this bad boy limping along for a little while longer.
Yeah, and I can imagine that adds some strain to your job, definitely. We'll come back to technology in a moment, but I do want to jump into some of the human capital. Again, it doesn't really matter what the industry is. Everyone is short of people right now, and I'm sure that every health system I talk to has a similar challenge. So are you able to staff properly? You know, what do you have to say about some of these signing bonuses that we hear about? And maybe it's more nursing, but maybe it's some other areas that affect technologists as well. But what do you have to say about this whole labor dynamic that's happening in our market right now?
The madness has to stop. That would be my statement. You know, yeah, we have some openings here. We have about a 10% vacancy rate right now, which is really pretty low when I hear what my peers have. I'll give you a great example. In the Indianapolis area, in that market, one of the big health systems up there, I got an email yesterday. They have 49 openings in the health system for rad techs. 49. Wow. That's crazy. Now, I don't know, those could be, you know, CT techs, diagnostic techs, MR, it could be a variety of things, but still 49 is huge. We'd done a little research not long ago and found that from the Indianapolis market down to the Louisville market, there were 57 rad tech openings for diagnostic in just that. I mean, it's the numbers are astounding. I've never ever heard of anything like this before. It's crazy. And it's people, you know, I think people are jumping ship for a lot of different reasons. You know, I think some of it is, you know, COVID. Some hospitals, you know, when COVID came along, they mandated people get COVID vaccinated. So some of those folks have said, adios, I'm not interested in playing there. You know, now as of last week, that's going to change. You won't be able to play in a hospital. You won't be able to work in a hospital if you're not, you know, at least until somebody, you know, files an injunction that sticks for a while. That'd be great. But you know, that's people left for that reason. And there were other people that due to COVID, they just left the market, and that's left openings. And the travel agency business is just, it's insane. We've offered, you know, what we've offered before for things, for techs, to an agency at a rate, and they come back and they go, that won't even touch it, man. You're not even in the ballpark. I'm like, how can we not be in the ballpark? Yeah. And it shifted so much, and there's so many openings that people can just choose and go wherever they want. And you know, that eventually I think that will all catch up, but we've got to really work together. So one of the things I've taken, an approach I've taken, is, my role in the, in the AHRA led me to become friends with some very, people here in Indiana and other radiology directors. So one of the things that we're doing is on Friday, we're having a meeting. I think there'll probably be hopefully 20 people-ish to maybe 25 radiology managers and directors, just to talk about how do we tackle this beast. Because my theory about it is we're going to have to figure out how to fix this, because nobody's going to fix it for us. So we got to figure out how do we do this. And it's a struggle. We hired somebody from a hospital north of us for a position here. And that person called Liz, who's one of my managers, and said, hey, they've had X number of more people have quit since I took this position. They really need me to stay until December. Can I stay? Will you let me come later than what we had planned? And Liz said, yeah, because we got to help each other out. We've got to try to figure this out, because it's not, none of us are gonna, nobody's gonna win. Nobody's winning right now. The amount of money that we're paying agency people, nobody's gonna win out of that. The only people that are gonna win out of that are the agencies. I'm not bad-mouthing agencies. They serve a great purpose. Absolutely no question. It's just this other phenomenon that's going on it's crazy. And if any other directors that are on here or anybody else that's on here that has figured out a way to fix this problem, just shoot me an email. I'd be glad to listen. But I'm hoping that in our call on Friday, we spend some time talking about just ideas people have, about, what they're doing there. And, if nothing else, we can all cry in our beer a little bit, because we're all in the same boat. I mean, that's the great thing about imaging, and great thing about our industry, I think, is we all are in the same boat. Maybe it's different boats, it's different ships. But we're all sailing and paddling in the same direction. Mm-hmm. And I've always found that we support each other and help each other out. And that's something that I don't hear when I talk to my peer leaders in the organization. So that's a great thing that I'm very proud of to be part of.
Yeah, I've been in radiology dedicated, I think, for the last 17 years, and I've noticed a similar kind of unified spirit that way, where people do want to advance their goals, but it's usually in the same direction as well. So good comment there. And again, just a quick comment to everyone listening. If you have other ideas, like Bill has said, maybe you can put them in the comment, or if you have a question, we can get to that at the end about how to improve the situation, because there is a finite number of resources, but if there's just signing bonus to steal from one another, the pot isn't getting bigger to help the industry. And I think that's what I'm impressed about with this. I don't know if you call it a summit or what you call it with this group in Indiana, but it's a good initiative.
Yeah, I didn't name it anything. I think I probably said, woe is me. It's probably what I said, just to get us all in the same room. But I think, I think that there's just been some, real kind of very disturbing things that have happened through this. I mean, I know somebody out in California that, the entire nuclear team left, gave them notice at the same day. I know somebody in, another facility that, they were having trouble, so they gave everybody, in MRI a $5 pay increase, and it just flips everything else upside down for them too. And it creates this dynamic, and it's insane. I'm at a loss. I wish I knew how to figure it out, but definitely trying to figure it out, and definitely open to suggestions if anybody has any.
Yeah, let's see what other people might have as comments or questions here as we get to the end. I just have two more questions that I want to get to, and then we can get to everyone else's questions out there. So we just talked about a lot of the employee side and the signing bonuses and so forth for employees. Is there anything you're doing to try to combat employee burnout? And again, that could be on the tech side, or things you're making to make your radiologists more comfortable, or just, I mean, the pressures are incredible, but just any tips that you're trying to ease the burnout feeling from all the staff that provide services for you?
Well, I think, one of the things is, with it being Radiology Week, Radiology Technology Week, we've done some stuff this week too, but we've been doing things. We've been, We've been buying food periodically. It's like, I know you guys are getting hammered. I'm bringing dinner in tonight. Or it's, I know you guys are getting hammered. We're bringing in ice cream. It's those kind of things that, and sometimes that's enough. Another time it's like, dude, I don't need that. I need a body. Get me a body. Okay, so let's figure out how to get you another body. And sometimes it's not a tech necessarily. It could be even we have tech assistants here. So, we'll float somebody to another shift just to help out because they know that things are, they're really struggling. So we're really trying to be proactive that way. I'm rounding a lot more. I'm trying to be out and thanking people, and I mean it from the bottom of my heart. I've been in there. I know how it feels. And it's that we got to keep that connection with the staff and our teams. I don't refer to my team as a staff. I refer to them as a team. We're all in this together. If one group's failing, we got to pick each other up, dust each other off, and move on. That's how I want it to be. I got to go around today and pass out some cups. We got cups for all the staff and put some little logo things on them and stuff like that. And it made it brightened the people that I was able to pass them out to today. I think the other thing we're done too is having our senior leader, our VP from our organization, has come down and rounded on the staff and made some thank you for being here and thank you for all you're doing, and I know you're getting your bottom handed to you. And we did that during COVID too, and it was really tough during the height of COVID because I think people really thought more about, when they kept talking about front line. The radiology was never mentioned when they talked about front line. That really, but they were, right? I mean, everybody that walked through the emergency room, got a chest X-ray, right? And everybody, those kinds of things. But it's keeping them to understand, getting them to understand that you don't have to be named as being part of that because you are, and we know you are, and that's what really matters. And I think that's where we try to really kind of keep people focused and focus on yourself and doing the great work that you do every day and the awesome things you're doing by helping your patients, and all that other stuff and what other people say doesn't matter. You know what you do.
Yeah, that's a good lesson for all of us, that we don't have to worry about what other people are saying so much. It is nice when the recognition comes, and I think getting your VP to come down is a great idea. The food and the ice cream is a good idea, but just the encouragement along the way, I think that's probably really good advice. Okay, so we talked about some of the challenges with the human capital, the people side of the business. That would kind of lend itself to does technology offer answers for some of these things? Maybe not all, but we've seen a lot. Probably going back 3-4 years to RSNA and other meetings where AI vendors, radiology AI vendors, are in full bloom, and I lost count. It's probably over 100 companies now that do this. But I just want to basically focus the question on: do you see radiology AI as being a way to kind of control some of these cost pressures you have? And is there any precedent for market consolidation among emerging radiology technology that you've seen in the past?
Yeah, it's kind of funny. I remember back in the early 2000s going to RSNA and walking out on the floor, and I think at the time it felt like there were 350 PACS companies. I mean, every booth you went to was selling PACS, and it was everybody's brother. And I remember telling the person I went with, I said, this is great, but it can't sustain itself. There's not going to be, this is going to end, right? There'll be 4, 5, 6, and I think today there's probably 4 to 6, maybe 10. But I think AI will be very similar. I think right now it's all very nichey. You've got lung nodule stuff going on, you've got some cardiac stuff going on. You've got now you're getting people that some AI stuff that can help read chest X-rays a little quicker, those kind of things. And I do think that is back to the earlier discussion we were having about radiologists and availability and their entrance into the market as a physician. I think there's some of that is a little spooky for docs. I mean, why would you want to spend your time and dollars going into a field as a radiologist that you see what's happening with AI and you think, 10 years from now, 15 years from now, am I going to be needed?
Yeah.
Will there be as many as you know? I would contend that yes, you will, because I don't see that AI can do every single thing that a radiologist does. But will there be some things? Sure, I think there are definitely. I think AI has to be looked at as an adjunct to what's going on and what's being read by a physician. It can't be, I don't think we're going to stick. I remember we were talking about DR. When DR first came on the scene, it was, well, when your image comes out, it's going to go through a reader and it's going to tell you exactly what's wrong with it and the densities that it finds, and it does some of that, but you still got to have a human eye to look at that. I mean, you just absolutely do. So I think there's that. So I think it will consolidate down itself at some point. But there's some really cool stuff out there. It's just, to your point, where do I need where and I only have so many dollars, right? Now I only have so many dollars because we had the discussion a few minutes ago that the pool of money is not getting bigger. The pool of money is getting a lot smaller, and I got to figure out where am I going to put my money, and that's the challenge. It's an ugly thing.
Well, again, these are kind of very common challenges, I think, amongst all providers across the nation. So your expertise and kind of your leadership, I know you're in the AHRA and other circles, so I think everyone has appreciated hearing from you. Lisa, this is kind of the end of our prepared questions, but maybe there's some other questions that have come in through the chat.
Yeah, we do, and the conversation has been great, and I'm sure those that are on appreciate all the insight. So we do have a couple questions, and for those that are on, if you have any questions, you can certainly add them now to the question drop down in your dashboard, and we'll get to as many as we can. And so our first question is, with the staffing shortage that we are now seeing, we have discussed changing how our pay is structured and moving towards tiered positions, cross-trained. We can perform 1, 2, or 3 modalities instead of different pay grades for each modality. We are seeing our general radiology staff moving to an advanced modality due to significant pay increase. They work the hardest and we pay them the least. Do you have any experience with this structure?
Yeah, we've had multimodality techs that work in diagnostic and CT for quite a number of years. So how our structure works there is they have to work actively in both, and they do get paid at a different rate. They do get a bump for doing that. At one point in time, we talked about having them clock in and out at a different pay rate. Throughout, like if this day they were scheduled here and this in CT, and then the other day they were scheduled in diagnostic, and finally went, this is just a mess because I want the flexibility of when CT goes, hair gets on fire, I can just move my diagnostic tech over to CT. I don't have to worry about them running the clock, and I don't have to worry about them fixing it because those people are valuable, to your point. I think that is a great way to start looking at that. Tier pay is something that we've talked about here and that we use in our organization periodically when we have shortages and people are covering shifts that they wouldn't normally cover for long periods of time. For example, FMLA, we have somebody on FMLA. Of course, right? During not only are we short people because people are leaving, we have people that are on FMLA because that's how it works, right? So, I don't think anybody plans it, but it sure feels that way sometimes, right? But I think that's a way that, we use that tier pay. And it's different. I've read a couple of different things in a couple of different forums that, people pay $7 an hour additional or $10 an hour additional or even 20, it depends. And that really, it trickled down. I think those kind of things really start at nursing and they trickle down to us. And I know for a fact, I believe every place in the country has been paying tier pay to nurses for a while. And I have no issue with it at all. I'm not saying that, but eventually it does get down to the imaging folks too. So.
All right. So our next question is, do you have any advice to those considering the use of AI going forward?
Well, I think for using AI, it's one of the things that we really haven't dived into too much. But I think we're going to be looking at it here more so. we have a very active lung nodule review board and a very active lung screening program. I think there's a niche for AI in there. We've just got to figure out who the right partner is for us. I think you really need to look at where is it going. What are you trying to get to? Are you trying to, fast track diagnosis? Are you trying to reduce radiologist reading times? What are those things that you're trying to get at by using AI? And I think all those can play a role in it. It's just we've kind of been working on trying to figure out what new equipment we need to buy right now. So, but yeah, I think there's definitely a place for it. I just don't think it's the only thing that's ever gonna, it's not the end all to be all. I think it's a tool. That's the right word. It's a tool.
Absolutely. Russ, do you have anything you want to add to that?
I was just going to say, I want to kind of echo what Bill has said. I've heard other experts in our field kind of talk about AI and its impact. And I think maybe the sentiment 3-4 years ago might have been, oh, it's going to replace all radiologists. And I think now the pendulum has swung back to being, it's a complementary tool. You're not going to really, maybe there are certain things that the AI can do all by itself, but I feel like the majority are saying it's very complementary. You still need the radiologist who's highly trained, specialized, and has the human reasoning to say, yeah, that's an extra nodule, or no, it's not. The human mind is still in a place where AI hasn't gotten to yet.
I take that back too. I think back to whenever you saw multiple vendors doing dose tracking. Everybody got hopped up on dose tracking. The ACR started talking about dose tracking when you track dose. And the reality of it is, if you have dose tracking, you're only tracking the dose in your facility. The minute that patient goes to another facility and has a study done, the dose tracking is only as good as what you have, because now it's off. So you just have to figure out what are the things that really work for you and your organization and make sense. It's just it's a personal choice.
Absolutely. Another question we have, and I know you mentioned when we started, you have a lot of irons in the fire right now, so this might be a loaded question. But what are you focusing on right now as a radiology group?
Right now I'm focusing on those 3 projects that I have going on that are going to go to our board on December 15th. So those are right up front. But I'm really focusing on the staff, on staffing and what we're doing with that. I have 2 great managers. I'm very blessed. Lisa and Liz are phenomenal people. And we talk about it almost every day. We text about it almost every day, trying to figure out what's going on, what they hear out in the market from other places, their friends, that kind of stuff. That we can get that information back to HR, to have HR say, I know what you're getting on this information from your market analysis you're doing, but here's reality, what's happening in the marketplace that we're seeing right now, and we're having people leave for, or people are telling us it's going on. So I think those things are the things that I've spent most of my time working on that right now, and just trying to figure out how we don't end up at 40%, or I heard about another facility the other day that they have a 50% vacancy rate of their technologists. I can't even fathom that. I just can't. I don't know what we do. We'd have to tell somebody no, and I think everybody that is an imaging professional on this call would go, "You can say no?"
Yeah, I'm with everything that is going on. Certainly the employment trends are not unique to even just healthcare. We're seeing it anywhere. So is there anything within that kind of growing employment trends? It's happening across the physicians, even within the radiology department that you're seeing. How is this also affecting the community hospital space? Are there any, because of all of this that is happening, are you seeing these trends affecting not just your department, but the community hospital?
Yeah, I think so far for us, we've been pretty lucky. We've not had to cancel procedures or roll back our schedules to not be able to provide patient care. But we have to look at from a community perspective overall, because we're the only hospital in the community. We have a community of 45,000 people. We're the one-stop shop. So, you know, we got to keep the doors open. So we have to figure out ways to do that. One of the things that we are doing, we have our own X-ray school. It's a small program. We only have 4 students. But as of July, we're going to expand this back to 6. We had 6 for years. So we had a couple years in the late 80s, early 90s that, man, maybe even a little later than that. I'm aging myself for sure. Probably in the 2000s then, late 90s, early 2000s, where we had students that would graduate, couldn't find a job. The market had totally flipped the other way. And so we cut our program back to 4. And now we're going to have to expand it because our last class graduated with 4 students and we didn't get to keep any of them because they all wanted to specialize or one of them wanted to be part-time and work in an office. So we didn't even get to keep any of them. So that's a challenge.
All right. Well, that was the last of our questions. And so, again, we certainly appreciate the conversation today and discussion. It has been very interesting to hear your perspective. And again, for those who joined today, we will be sending out an archive here in the next couple weeks. And if you could, please complete the survey that will launch immediately following the webinar. Once we hit close, we would really love to hear your feedback. And if you have any additional questions, you can certainly ask us during that survey. Russ, is there anything else you'd like to say before we close?
I'd just like to thank Bill. Thank you for your leadership and your friendship for all these years. I do appreciate you sharing your perspective today. Thank you so much.
Thanks, I appreciate it.
Absolutely. Thank you, Bill, and thank you, Russ, for today.
All right. Goodbye, everybody.
Take care.